Ladies and gentlemen, I would like to introduce you right now to Dr. McCracken. He is a board certified neurosurgeon. He is fellowship trained in neurosurgery oncology from Emory University and is currently the co-director at Piedmont Atlanta Brain Tumor Center. He was an early adopter of GammaTile and is now instrumental in conducting several GammaTile clinical studies. And again, Piedmont Brain Tumor Center is located in Atlanta, Georgia. And he, again, is going to talk about GammaTile therapy, and specifically, he's going to talk about a clinical trial they have called START, S-T-A-R-T. And I am hopeful that Dr. McCracken is joining us.
I'm here.
Hi, how are you?
Good, how are you?
There you are. Good to see you, and thank you so much for coming to talk to us today.
You're welcome. I'm happy to do it. Well, let me share my screen, if you don't mind. All right, can you all see that?
Give us a minute. There we go.
All right, very good. So thank you so much for having me.
Of course.
My name is Jay McCracken. I'm a neurosurgical oncologist here in Atlanta, Georgia. And I'm really here to talk about our experience with GammaTile as it relates to treatment of brain tumors. And so if you have questions, please stop me. I have some pictures and videos, and so hopefully this will be a great experience for you guys. So I won't belabor this too much, but everybody knows the scope of malignant brain tumors, which is what we are aimed at treating. In general, the most common things are brain metastases, gliomas, and malignant meningiomas. Just to give you sort of an idea of the incidence, metastases, over 100,000 new patients a year, and those occur from breast, lung, colon, renal, melanoma, everything you could imagine. High-grade gliomas, of course, the most common is a glioblastoma, which is 3.5 patients per 100,000, so over 11,000 new cases a year in the United States. And then meningiomas, thankfully, the vast majority are benign, but the ones that we are aimed at treating are either atypical, which are WHO grade 2, or malignant, which are WHO grade 3. And so what is GammaTile? Where does this come in? Some of you may have heard of it. We have patients who come see us all the time specifically asking for and looking for GammaTile. It is a relatively new therapy, which was initially approved by the FDA in 2018 for all types of any recurrent intracranial tumors, so it's sort of tumor tissue agnostic. And then in 2019, it got an additional designation for the upfront treatment of newly diagnosed malignant brain tumors. So you can use it for GBM metastases in the upfront setting as well. It's a very small collagen tile. You can see there's pictures of it. It's a 2 centimeter by 2 centimeter tile, about the size of a quarter, actually. It's bioresorbable, so that actual white piece will actually biodegrade over time. But within it, there are 4 small titanium seeds, which contain a radiation source called cesium-131. And what happens is that after you have done a surgical resection of a brain tumor, no matter what kind of brain tumor it may be, we then implant and line the cavity with these tiles so that radiation starts working immediately to sort of treat any remaining tumor cells which are left behind. This allows for immediate treatment of tumor, especially in somebody who's going to need some type of adjuvant or external beam radiation. It allows us to immediately identify the areas because as anybody who's planned any sort of post-operative radiation, sometimes planning the cavities can be very difficult. It minimizes the dose of radiation to the normal brain and ensures really an excellent compliance for the patients. And one of the best things about it is that most patients do not have to come back for any sort of other form of external beam radiation after that. So it's kind of a one-stop shop for a lot of patients. This is a sort of a cross-section about what they look like. And so in there, you can see the small dots. Those are actually where the titanium seeds are located. They are structurally offset from the actual surface where they're placed. And so when these are placed together, and we typically place them end to end, we don't typically overlap them, they are designed to achieve a 60 gray dose of radiation. And some of you who have either treated or experienced glioblastoma, that is the same dose that we prescribe for glioblastoma patients. And typically that's delivered over 30 fractions or 6 weeks of radiation. This is the same dose that is delivered within the surgical cavity at the time of surgery over a period of 6 weeks, but without having to come back for external treatment. And so these radiation sources have a half-life of about 10 days, which means that over about 6 weeks, 95% of the dose has been delivered. To give you an idea about what a radiation plan looks like after these are implanted. So on the left, you can see just a simple CAT scan. In the CAT scan, you can see the small seeds within the cavity. That's what they look like. And in the middle picture, you can actually see what the radiation dose looks like compared to the rest of the brain in that cavity. In comparison, a standard external beam radiation therapy plan is shown there on the far right, and you can see how much radiation dose is actually delivered to the entire sort of right parietal and occipital lobe, as well as some of the left parietal lobe with the standard external beam therapy plan. So one of the wonderful things about this therapy is that it really minimizes the external dose to the other parts of the brain and allows for other parts of the brain to be treated with other radiation if needed in the future. So we talked about what it's indicated for. The key considerations that we think about when we're talking about these patients, or if they're a good candidate, obviously they have to be a good candidate for surgery. We typically want to make sure that the tumor is resectable. We typically don't do these in patients who just get a biopsy. And I personally look for, can the tumor either be removed completely or almost completely? If you feel like you can only remove a portion of it or half of it, this really is not a good therapy. Obviously, the tumor has to be operable. Do they need radiation? And one of the biggest things that I felt that this is a tremendous help with are patients who either have transportation issues, so they either cannot make it back and forth to external beam radiation plans. They're going to have follow-up or compliance issues. So we have a lot of patients in Georgia that we lose after they've been treated once, and we never hear back from them. And so this sort of ensures built-in compliance. So we know after they get their surgery, they're absolutely going to get their radiation, and we don't have to worry about them coming back to get their 6 weeks of radiation. Additionally, this is also fantastic for patients who come in and they're already maybe very severely neurologically devastated. They can't move their arm and leg because the tumor is affecting them, and we know they're going to have to go to rehab. In general, especially in Georgia, if patients go to rehab, they cannot go back and forth for radiation. And so oftentimes there's a significant delay in getting therapy. So if somebody has to go to rehab for 2-3 months after surgery, that prevents them from getting radiation, which is typically not standard of care. And so being able to give them radiation and then go to rehab is a tremendous benefit. And so I'm just going to show one patient example because I know I only have about 10 minutes, but we've used these in every tumor tissue you could imagine. This is just a example of a lady with a recurrent metastatic breast cancer. Started her journey in 2016. Prior to seeing us, she had had 3 separate rounds of single fraction radiosurgery to 5 different lesions within the brain. When she finally came to see us in January of 18, she had a new left cerebellar metastasis that we treated with GammaTile radiation only. This progressed to a very large lesion, and then we ultimately took her to surgery to remove this. Standard of care is to give her post-op radiation, and she got a 13 fraction treatment. And then this progressed once again in 2020. And so this was actually the first patient that we treated. And so on the left, you can see this is an axial cut of her MRI, which shows this very large metastasis in the cerebellum, abutting and adjacent to the brainstem. It's attached to the undersurface of the tentorium. And so this is a very nasty tumor. And honestly, the radiation oncologist felt like she did not have any further radiation options. And so he said, this is really the only thing we have left to treat her. And so we took her back to surgery. Thankfully, we were able to remove the entire tumor at the time of surgery. And then we implanted 6.5 GammaTiles in her. This is actually her video, and I'll just preface this by saying if somebody is maybe a little squeamish, then you may want to hang tight for a minute. But this is just to show you what the GammaTiles look like when they're implanted. So this is actually looking, this is through our microscope at the patient's brain. The tumor has been removed. And so now we are going to line the normal cavity, so the normal brain that we know has brain metastasis cells still in it. There's still stuff that we cannot physically see. So these tiles are they're wetted. They're easily placed with just a simple bayoneted forceps. We typically don't wear lead shielding. We don't wear special lead gloves. The radiation dose fall off is so quick, you really don't need to protect yourself in the operating room. And so these tiles are just placed sort of side by side, end to end within the cavity. And remember, all of them have 4 separate radiation seeds within them. And so that allows for a very conformal dose, very even spacing of the radiation. And we just sort of place these until there's really no more room. The trick for us is typically figuring out how many tiles to order beforehand, because you do have to order them beforehand. So typically we err on the side of ordering more and then using less if we need them. But ultimately they're very easy to place, and then we just close like we normally would from a surgical standpoint. This is her postoperative picture, showing basically what the radiation dose looks like in that area. The red is actually the 60 gray line, so the same dose that she would have gotten for a glioblastoma dose, but delivered over 6 weeks internally, as opposed to having to come back and getting a external dose over 30 treatments. And this patient actually did miraculously well. She lived for well over a year without any progression in the brain, and then ultimately succumbed to her systemic disease. But this was truly a win for this patient who really had no other options. So our series includes about a little over 50 patients. So we have 52 patients. The vast majority are metastases, 30 either newly diagnosed or recurrent glioblastoma. We just hit our 3-year mark, so our first patient was in 2020. From a brain metastasis standpoint, we've not had any local recurrence, so anything within the initially treated resection cavity. We've had a significantly delayed progression in all of our high-grade gliomas, so 6 to 12 months more than what we typically would have expected after a recurrence. We've not had any progression in malignant meningioma patients. This is more from a surgical standpoint, but we've had, there's a concept called radiation necrosis in patients who have previously already had radiation dose. And so sometimes it's very difficult to tell if it's truly recurrent tumor versus necrosis. And so we've had 5 cases that we took to surgery that ultimately ended up just being a necrotic lesion. And so we don't implant GammaTile on top of that to make the necrosis worse. This can cause radiation necrosis or inflammation of the brain secondary to almost too much radiation. That's typically people have had many doses of radiation in the past. And out of our patients, we've had 4 that have experienced that. 1 wound infection and 1 spinal fluid leak. And so from a surgical complication standpoint, it's actually well within the normal, sort of realm of surgical complications. And so we've actually been very pleased with this therapy, and our patients have really done well with it. There are 3 active trials going on and 1 that's about to come on. The first one is actually a feasibility study called Gestalt. Gestalt is it's basically an upfront treatment of glioblastoma. And so this is one that I'm truly excited about. It's, some of you may have heard of the STOOP protocol, which is after surgical resection. It's 6 weeks of radiation plus temozolomide. This is trying to jumpstart that whole process. So as opposed to waiting the 4 weeks after surgery to start radiation, we take the tumor out, we put the GammaTiles in, the patients then wait 4 weeks and they get an abbreviated dose of radiation as opposed to the full 6 weeks. And so the hope here is to see, does this prevent progression earlier? And are the patients able to tolerate this? And so ultimately, this will likely progress into a full-fledged clinical trial. Next is the Rhodes study, which is a randomized controlled trial for brain metastases. And so patients are either randomized into resection plus GammaTile or resection plus standard of care postoperative radiosurgery. and then to compare the results. And the hope is that the incidence of both radiation necrosis and leptomeningeal disease that can happen after brain metastases resection is lower, and local control is as good, if not better, with the GammaTile. There's a new study coming out that's going to be for recurrent GBM, and so we don't have the final details on that, but there will be a third study for recurrent glioblastoma. And then we also have a registry study, which basically looks at anybody implanted with GammaTile, whether it was meningioma, upfront or recurrent GBM, upfront or recurrent metastases. All these patients are then monitored sort of in a real world fashion moving forward to see how well they do. So I'll stop there and take questions if anybody has any.
Thank you, Dr. McCracken. That was amazing. I want to compliment you on your slides as well. Those are really great looking slides and easy to understand. Thank you.
You're welcome.
I have a quick question. Actually, it's not really a question. Can you explain again your point about GammaTile radiation and rehabilitation? Can you explain that again? That's really important.
Yeah. So, we have a lot of patients who come to us and they're already pretty severely debilitated. They've not had an arm that works for 4 weeks, and they just haven't gone to go get treatment. They, have had a severe speech or aphasia issue, or they're bedbound for whatever reason. And so these patients come into our ER, and we know that patient, certainly they need surgery. Very likely they're going to need adjuvant radiation therapy. Where we have started seeing a tremendous use in this is really because those patients are going to have surgery, and then we know they're going to have to go to rehab because they are not going to be well enough to go home after surgery. Rehab typically delays the time until they can get radiation therapy, and sometimes it can be months. And so if we say, we don't want you to wait, you've got a highly malignant brain tumor, we want to take it out, but we want to get you treated so that you don't have to wait 2 to 3 months before you start radiation, because in that time, these tumors can come roaring back even before they even start radiation. And so for us, it is a tremendous benefit to be able to say, let's give you surgery, give you GammaTile so that you're starting radiation early, and then you can go off to rehab, and we don't worry about them not having a rapid early progression of the tumor.
Thank you. That was really important.
Yeah.
Does anyone else have some questions for Dr. McCracken?
Dr. McCracken.
Hi, good morning.
Good morning. I had 4 tiles implanted on my second surgery, and I'm fine.
Wow.
I'm at 27 months, and I'm doing great. I couldn't even tell they were in. So yeah. I'm all for GammaTiles.
Yeah, that's I'm so glad to hear that. We have very similar success stories. I'm so happy it went well for you. I mean, we've used it in recurrent glioblastomas for a lot of patients, and they have basically gone on about their lives and almost like nothing ever happened. So I'm so glad to hear that it went really well for you.
So I'm not clear on this. For GBM, for GammaTile therapy, I know it's FDA approved, but is it approved as for standard of care?
So that's a good question. So standard of care as it stands right now is STU protocol, right? It's surgical resection, what we call a maximal safe surgical resection, followed by, and then 4 weeks later, you start STUP protocol, which is 6 weeks of concurrent radiation and temozolomide. So that's standard of care. So right now, having GammaTile in the upfront setting for newly diagnosed GBM is technically not standard of care. That's why these trials are ongoing, to see if it shows a benefit. And then hopefully, if we say, hey, this is doing really well, could this be included in the standard of care paradigm?
Thank you very much. And upfront care means what you're going to receive right at the beginning of your diagnosis, including
Correct.
Surgery. So that's upfront. All right. Thank you so much. That was amazing. So we have your contact information. We are going to show all these. We're going to share everything that we can with everybody who registered. So if you have any questions whatsoever for Dr. McCracken, please reach out to him directly. He is a wealth of information. He's a GammaTile expert, and we can't thank you enough for presenting today. Thank you.
You're welcome. Yeah, please call, email me, find me on Facebook or Instagram. You're welcome to.
Dr. McCracken is, by the way, very, very active on social media, and we will be sharing. Oh, here it is, right here in front of us. Feel free to reach out to him via social media as well. Thank you.
You're very welcome.
Have a great day.
Bye-bye.